Thank you for inviting me this morning. I have a few minutes of just a short presentation, and I would prefer more interactive communication with all the participants and also all the listeners here. So thank you again. And the topic is very much a trend over the past few years regarding snake bites or snake-related injuries, we call it, because we in Malaysia not just deal with snake bites, but also other forms of injuries such as strangulation. Some of the big pythons that we have in Malaysia can strangulate and kill, especially children. And also another type of injury where the venom is sprayed into the eyes. So that can cause what we call a venom ophthalmia. So it's not just a bite from a snake, which can be from a venomous snake or from a non-venomous snake. Okay, so this type of injuries can also cause a mechanical problem or mechanical injury, which may not be related to a venom in a snake. So the first thing that I want to bring out here is to ensure that to make sure that you understand that a snake does not mean all snakes are venomous, and not all snakes are dangerous. But some of the even non-venomous snake can cause danger to humans. Okay, and we are talking in a specific group now in children. But the thing about managing snake bite is it can be applied for adult patients or adult population, or even for the pediatric population. All right. Okay, so our objective is simple. It's just to provide appropriate treatment because we are now in the hospital setting, and we want to maximize the outcome of the treatment that we provide to our patients. Okay, so if you understand the system in Malaysia, we have the primary care, and then we have the hospital care, and then we have the specialist care. So in the primary care, there's not really much things that can be done if a child comes to you with a snake bite or history of bitten by a snake or whatever involvement with a snake. Most of the time it's a snake bite, but some may just, feel that they are in contact with something that they think is a snake. Okay, so most of the time in Malaysia, these are actually not established whether the patient is really encountered a snake or some other animals. And sometimes even if it was a snake, patient saw a snake, they cannot identify it. Okay, they don't know what it is, and they did not take any picture of the snake that they were in contact with. So it makes things a bit more difficult when we are trying to establish a diagnosis for this patient. So, but in the primary care, let's say for example, our klinik kesihatan or GP, the things that can be done is quite limited. They have, of course, in emergency situation, we provide all this ABCDE assessment of the patient, the primary survey of the patient. History of the snake bite or snake encounter incident is very, very important. It has to be very detailed in order for you to get a better picture of what really happened. Sometimes patient came, they are in a state of panic, they're in a state of apprehension and so on. They couldn't give a good history, but we really need to establish this history maybe a bit later on. So when the patient, for example, a child brought by the parents, did the child say anything that can help us in terms of establishing the history from the incident itself. So sometimes this patient may have done some what we call pre-hospital care intervention, or what we call first aid, right? So many types of first aid that have been done in our country, all kinds of things. One of the most famous first aid is actually to tie or to do tourniquet on the limb that was bitten. Okay, another more common issue is patient or family of the relatives, or for example, when they see the child, they will start massaging the bitten area, and massaging in the hope that it will actually express the venom out of the bitten wound. Okay, so these are all proven not to be working. It actually can cause more harm. Massaging, for example, will make sure will ensure or will cause the venom in that site that was bitten to spread to the whole of the body through the lymphatic system faster. Okay, so we only encourage to do immobilization, because when you immobilize the limb, you minimize the movement of the bitten area, and also it can cause it can actually help in terms of pain, of course, but most of the time is to minimize movement of the venom from the bitten area to the lymphatic system, and movement in the lymphatic system will cause it to go into the systemic system, okay, to spread systemically. So that's why we immobilize, or we ask someone not to move too much or calm down. All this actually just to minimize movement until they reach the hospital. Okay. In the primary care, we see in Malaysia a lot of people still give the common things that when they arrive and somebody got bitten by an animal, no matter what, our KK and so on, they will start giving IM Voltaren, apa lagi? Hydrocortisone, okay, lagi ATT, right? Some even give Piriton. So for what reason we don't know. The patient did not present with any signs and symptoms of allergic reaction, but they still get it. They say, oh, this is for prevention. Okay, so in Malaysia, this is still, some of it is still being practiced, and we have been discouraging these practices being done in the primary care. So we only treat when the symptoms of allergic reaction occur, right? So if you still see your colleagues or your friends or your staff doing this, please ask them not to do it anymore. Okay, follow the guideline that we have provided by KKM. All right. So appropriate analgesia in the primary care, in children, there's nothing much we can give. Probably some suppository PCM, or some people will say you should not give orally. But for snake bite, it's okay. That's not really much of an issue, except if there is a bite by a neurotoxic snakes, okay, that can cause somebody to collapse or paralyze, and therefore unable to swallow well. So that can actually potentiate someone to get aspiration, right? Respiratory, aspiration of the whatever that they have eaten right before the incident. So you can ask the patient not to eat anything, but actually the most important thing to do is to transfer the patient to the most appropriate hospital. And in Malaysia, this is actually considered to be government hospital. For snake bites, is for government hospital. The reason being, I wouldn't say that you should not go to private hospital, but the private hospital don't really have the appropriate enough in terms of antivenoms stock. We don't know. Okay, but in government hospitals, so far over the past 10 years, we have made sure that each hospital has the appropriate antivenom. Okay, they may not have enough, but they have it, and if they don't have enough, we know where to source the antivenom from. Okay, from other nearest hospital, and we share resources. So we've been doing this for years already, and so far, alhamdulillah, is very good. Okay, so transportation, of course, you may want to consider ambulance service to make sure that the patient is well monitored during the transport process. Okay, so what then happened when the patient arrived to us? Mainly in the emergency department first. Okay, obviously we will start doing all the ABCDE as we have already mentioned. So appropriate hospital at the moment, government hospital, including university hospitals. So we will actually do this process from the start to the beginning. So if it's a snake bite, is it alleged snake bite? We still don't know what it is. There's no picture, no specimen brought with the patient. Or is it a confirmed snake bite? Means that there is a specimen with the patient that we can identify. And all of this process of the management flow, we can always contact what we call remote envenomation consultancy services. Okay, even though patient already arrived to you in the ward, pediatric ward, but you can see there was no real consultation to REX, you yourself can actually contact REX and initiate the consultation process. So the whole thing is actually to make sure that the patient arrives in a very a safe environment where we continue monitoring the patient, because things can go south very fast, especially in children, and especially also if a child bitten by the snake, neurotoxic snake, okay, it can collapse. The child can collapse within a few hours. Okay, but if it is a hematotoxic snake, you need to actually monitor the patient serially and closely for the event of coagulopathy. So therefore, you will look at the possibility of getting, taking blood test. And the blood test that we use is actually only three things. One is FBC, two is coagulation profile, and three is the CK, the sign of symptom of tissue injury. Okay, so these are the three components of investigation, as you can see in the management. Part of it is actually investigations. So these are the only three things that we normally ask to do, and we need to do it serially every 6 hours. So you're looking at poking the child every 6 hours. So maybe you have to strategize how you want to take this blood test, especially if it's very young child, maybe 1 or less than 1 year old or 2 years old. It's going to be quite challenging in terms of getting this blood test. All right. And every 6 hours, if you want to monitor closely. So yeah, you have to inform the patient and also the parents early that you may need to do all these things. Child may be crying every 6 hours. Okay, so identification. Just to give you a brief overview of how identification is like here. Now it is a real challenge. Now the patient doesn't come. Wait, not all patients come with a snake that is whole. I mean, alive and well and looks beautiful. Okay, maybe it's scary for you, but for some of us, snakes are very beautiful. But in real, if in real thing, they will most of the time will bring a dead snake. Okay, they will have a snake that is already being killed by whatever method, and they present, doctor, this is the snake already in the bag, dead. So what do you think this snake is? Is it a dangerous snake or not dangerous snake? Anybody? Okay, what feature do you see? Is green color, the tail is red in color. What about the head? What's the shape of the head? I just want to know, show of hands later, maybe how many think that is dangerous or not dangerous?
Ular daun, not dangerous.
Oh, not dangerous. Hula daun. Okay, so this is not hula daun, but you are right. This is not dangerous. Okay, why? Because some people mistaken that everything that has triangle head. You can see the head here is triangle in shape, right? People think that everything that has triangle shape is viper or pit viper, and therefore is venomous. So this is not true. This is actually a green, it's a red tail racer. It's non-venomous snake. Okay. What about this one? Look at the head as well. The shape of the head is triangle. Dangerous or not dangerous? Okay, you can see the staff that's holding the snake using, yeah. So, but anyway, this is also killed and brought to the hospital. The patient is there. This is the snake that he brought. Again, triangle head. Is this dangerous? Okay, this is actually a non-dangerous snake. It's called Boiga cyanodon, or uh, uh, dog tooth cat eye snake. So there are three different animal in one animal. Cat, dog, and snake. Okay. So nama dia pelik sikit. So this is actually a boiga. Boiga is actually is a venomous snake, but in terms of the venom, is not really dangerous to humans. Okay. So it's not a pit viper, even though the head looks like triangle. Okay. So that's again another misconception. People think that everything that this feature we learn from Hollywood movie and so on, from America. Triangle head means pit viper, which is not true. So this is another snake that we also encounter quite frequently. What do you think? The belang-belang, black and then white belang. We say that everything that is belang-belang is dangerous. So this is a water snake, and this is a baby water snake. Okay, one of the Homalacius buccata. This is actually not really how should I say, common as the other one, but this is actually quite common in some areas where there are water, there is a apa nama sungai, and also maybe paddy field, okay, a river. So because it's a water snake, it eats fish in the water. Okay, so this is not dangerous, but people say ular belang-belang is actually dangerous. It's not true. Okay, what about this one? Look at the head, fully smashed. So this is the other water snake that I mentioned just now, more frequently encountered. This is the rice paddy water snake, or puff-faced water snake. It is not dangerous, okay, but people say it looks like a cobra. Okay, every snake it looks like a cobra anyway, right? So this is not actually uh, something that we have to trust. When a patient express something, doesn't mean that it is actually true. So we have to take everything with a pinch of salt, maybe a few spoons of salt. Okay, what about this one? Is well, it's even worse. The murder scene. I can't even imagine what the scene looks like, but the victim is like this. Almost decapitated. Okay, but we still can identify it. So this is actually a mangrove pit viper. Okay, you have it in Kedah as well. So this is a mangrove pit viper. How do we identify it? First, is actually the red eye color. Okay, not the lidah, the eye, and then the scales, and also the patterns on the body, so we can identify it. So this is actually a mangrove pit viper. All right. What about this one? This is even more kejam. Dah lah dibunuh, lepas tu disiatnya kulitnya lagi. So the Malaysian is, I don't know, they can be very brutal at times. So how to identify like this? But yet we can still identify even though we don't have a full snake. So this is actually one of our coral snake. Okay, one of our coral snake, Malayan blue coral snake. Okay, the red tail, red head, and the body is bluish in color. Okay, so this is a venomous snake, coral snake. Coral snake doesn't mean it is in the sea. Okay, the name coral snake is referring to the beauty or the color that it has, like a coral. Okay, so it lives on land. It's a land snake, not a sea snake. Alright. Okay, so what about this one? Dah kau badan je dia bawa, kepala dah tak ada. Right? No head. So, but we still can identify it. If you consult Rex, we can identify. This is a Trophodylamus regularly. You have it here in Kedah and mostly in Penang. You go to Penang Island, you go to the snake temple. You will find this snake in the snake temple. But I can tell you again, this is a male Trophodylamus regularly. Tak ada kepala pun tak apa. I can tell the sex, just the gender. Gender sekarang ni jadi isu LGBTQ punya brain. Gender is not just male and female. Gender is all kinds of things. But sex, yes. But anyway, so Trophodylamus regulari ini is mainly in Peninsular Malaysia. In Sabah Sarawak, they call it. There's another Trophodylamus species called Trophodylamus subannulatus. So you go to Penang, you can see two types, two colors. One big blackish color and this one small greenish color. So the small greenish color is the male and the big black color is the female. This is very interesting snake where you have only dimorphism of the gender between male and female. It's remarkable. But yet they can produce baby. Yes, very unusual, interesting. Anyway, nak kau patient bawa ini je. Ni batang kayu ke apa ni kan? We think, kepala tak ada, ekor tak ada. Pada tengah-tengah je, doktor, mana kepala, mana ekor? Saya dah tinggalkan tempat kerja. Saya chop kepala, chop ekor, ambil badan je bawa. Doktor boleh identify. So yes, we say of course. So this is first thing where we need to understand, where history will help us. So the first thing we ask, where was the incident location? Right, where was the incident location? So this incident was on Cameron Highlands. Okay, so straight away we identify already that there are species in Cameron Island which is unique to Cameron Highlands because of the altitude. Not all snakes can live at all the altitudes. Okay, and not all snakes are living in all area of Peninsular Malaysia or Sabah Sarawak. Some of them are here, even in Peninsular Malaysia, in the north and the south, it's different. Okay, so we have our own different geolocation for each species. So this one of the thing important to note as well that we provide in our information on the land snake of medical significance. I think I given to Lim all the notes for you. You can actually have a look at it. Okay, so this is actually Ovophis convictus, a mountain pit viper on Cameron Highlands. In Sabah, and so they have a different mountain pit viper, different. Okay, so this is what it looks like. From the color also, I can tell that this is actually a young overfish convictus. Okay, this is what it looks like when it is still a baby. This was what I rescued before. It lives with me for several months. You can see very cute, very pretty, baby. This is a baby. This was taken at my house. Okay, in KL after we rescued it from Cameron Highlands. Anyway, so this overfish convictus. How do we know that we can identify? It's because of this patterning on the body here. Okay, and you can see the patterning on the body here. So when it grows mature, baby looks different. When it becomes teenager, looks different. When it becomes adult, even more different. Okay, so that can be confusing as well. For example, not those who are not familiar with snakes. So that's why you call Rex, and we can actually help you with the identification process. So anyway, how do we then proceed with the diagnosis and assessment? So first diagnosis, you have the specimen, you get now the identification, either snake ataupun tak ada snake. So we need to know the history. As I said just now, the time is very important. Different snake will actually active at different time of the day. Some active at night, some active both day and night. And then of course, the location, as I said just now, is it how high on the mountain? Is it on the tree? Is it on the ground? Those things are all very important information that we'll be asking. When you consult to Rex, you might find that all the questions that we ask looks stupid or looks strange, but there's a reason why we ask those questions, the details that we ask for. Okay, because it will help us, especially those who do not bring the specimen with them. We cannot identify, but we can still get some idea, and then we observe for the sign and symptoms, or we use what we call the syndromic approach. Okay, so these are the questions that we always ask, and the most important is also the specimen. Kalau ada specimen, we have to provide the name of the species. Okay, it's not life has been taken. Most of the time they will kill the snake. At least give some respect to the snake that they provide the punya life for us to identify. So give it a name. All right. So anyway, so this is the diagnosis that we can actually utilize. First is if it is a identified snake bite. So the way we write in our diagnosis, this is when the patient arrives, the working diagnosis in emergency department. Is it an identified snake bite? Kalau ada specimen dan ada gambar ular, actual gambar ular yang gigit dia tu, then we have to verify the species, and therefore we have to write down the name of the species in the diagnosis. So bitten by, for example, Caliophis intestinalis. Tadi bitten by Tropidolaemus wagleri, the scientific name, okay? Because we are science people, right? Okay, so most of the time, sometimes kita tak boleh nak identify the snake because the patient did not bring the snake, or the patient did not take a picture of the snake, but they know there was a snake, the bite. Dia nampak ada ular tapi dia tak tahu apa benda. Nak describe color, green color or brown color, okay, or black color, but there's no evidence that the patient bring to you. So this is what we classify as unidentified snake bite, but we still can actually get some what actually beat the patient by the information that they provided. Okay, venom ophthalmia is when I said just now, some snakes are actually one of the snake species only in Malaysia that can spray venom, bukan spit venom. Dia tak dia tak ada bau macam tu. So they spray the venom from the fangs, okay, and then it enter the eye. So this only can be produced by a species called the Naja sumatrana or equatorial spitting cobra. Nah, nama dia pun bahasa Inggeris spitting cobra. It's a misidentification. Actually, it's wrong term to use. So you see, they spray venom and can go into the eye. Dia tak guna venom ni yang they spray to kill you. No, it only to deter you or to make you go away, because you're in pain, or for it to give time for it to look for safety, run away from you. So there's a typical, or the only reason is spray is for defense mechanism. For it to eat others, a mice or something, they will still have to bite and deliver the venom into the snake, into the mice body to paralyze it. Okay, so if let's say if the patient doesn't know what it is, okay, tak nampak pun ular tu, tak boleh nak describe ular tu. So it could be, but there is a puncture wound, for example. It can be an bite or sting by an animal. Okay, Then and also two puncture wound doesn't mean that it is a snake bite. Okay, this you have to bear that in mind, because you know you can still be stung twice by a scorpion, right? You still get two puncture wound. You can have two puncture wound from a bite from a centipede, for example. Those are the common things that we find. The other one is, let's say dia tak nampak apa pun yang animal tu. So centipede ke scorpion kita tak nampak. So it's only we can put as unidentified animal bites or stings. Okay, and again, all this diagnosis will require you to perform the serial observation of the patient. Okay, close serial observation of the sign and symptoms of possible envenomation. Right. So what do we do? So most of the time when we child arrive to us in the emergency, we will do the rapid clinical assessment, and then we intervene as per resuscitation for each part of it. Okay, and we always manage this patient in our P1 or P2 or resus or yellow zone. Okay, and I said just now, our approach is simple, similar to all emergency, which is ABCDE or primary survey. Okay, and we treat the or resus as indicated for each of the ABCDE. Okay, the limb, if it is a pre-hospital care, yes, we can consider immobilizing. But in the children, in order usually when the patient, arrive to hospital, we remove already all the immobilization. Okay, because patient doesn't move much in the emergency department or hospital, you will lie in bed. So but if a child, sometimes it's difficult to restrain the child, so where therefore immobilization of the limb still continue for pits if the child doesn't stay still. Okay, but if the child can be cooperative and the patients or the parents are there to help, the child can stay still, not moving too much, then you can actually remove the immobilizer. All right, but still need to be tak boleh berlari-lari, still on the bed. So bed rest is very important in snake bite management, especially in the acute phase. So the clinical examination that we look for is the general sign and symptoms and venoming, or specific sign and symptom for each one of the type of toxins that the snake produce, and look at the bite site. Okay, this is very important, and we always ask doctor to take serial picture of the bite site as it evolves over time. You can see sometimes there will be nothing, and in the beginning suddenly the redness, and then just a few more hours later it becomes darker purple color, and it becomes black. There's a progression, and then it's not just there, you can actually spread and actually expand as well. So picture over serial time will help you build a collage of how the progress is. Okay, so that is very important. Now, neurological dysfunction, one of the commonest presentation for our snake bite in Malaysia is from what we call the elapid group, which is the cobra. Okay, that's the most common cobra bites, especially in Kedah also cobra bites. So dia tak nampak apa, dia kata black snake saja, doctor. Okay, so for that we need to also examine for muscle tenderness and rigidity. This is actually why we do the CK. CK can actually raise either from the wound yang becomes necrotic just now, or actually somebody got bitten by a sea snake. Okay, they can actually cause muscle pain, rhabdomyolysis. Okay, and also the urine color becomes black. But in terms of the bitten area, some snake can cause a lot of local tissue injury, but some just a puncture wound. But some progress, as I said just now, can cause, like for example, bleeding from the bite site. Bleeding from the bite site can be just transient, can be just very minimal, or can be continuous oozing, especially if those bitten by pit vipers. Okay, and the fang size can actually affect the how it appear on the skin. So like for example, cobra, the fang is very small. The sea snake, the fang is very small. Even coral snake and so on, they are all very small fangs. So nampak macam very minimal scratch sahaja on the screen, or many very small tiny puncture wound, but it can actually cause problem because you don't take it seriously, therefore you don't observe the patient can just collapse a few hours later. Okay, Besides that, we need to observe for the extension. So just now I said about the tissue necrosis, but some of it, as it can cause a serious edema, and the edema is progressing proximally through the lymphatics. Okay, our lymphatic doesn't some can spread distally through the soft tissue, but through the lymphatic is actually always proximally. Okay. So that's why we say it's called painful progressive edema proximally. All right. So we observe for this progression of the swelling as well. And then we palpate the lymph nodes. Do not forget, as I said just now, the venom spreads through the lymph. Therefore, it can cause lymphangitis. Okay. So, and the lymph nodes, the earlier lymph nodes draining that lymph needs to be checked. Those are the signs where it can help us when to give antivenom or not as well. All right. CRT, don't forget, capillary refill time, and also what we call the pain score progression. So the arrive time berapa, beaten time apa dia pain score, arrival to emergency apa pain score, and every hour after that. So this is called pain score progression, part of the observation that we do. So this is an example, somebody got bitten by a snake. You can see there's a blister already forming at the bite side, and this still nampak macam swollen, and the CRT is definitely going to be reduced here because of the swelling, right? So this swelling of the digit can be dangerous because it can cause necrosis as well, or hypoxia. So most of the time, somebody who got bitten on the digits like this probably will be indicated for antivenom. So this is an example, a child you can see bitten by something on the foot here, bluish color. This is ecchymosis. It's not necrosis, it's ecchymosis. And then you can see the swelling. So the doctor marked with a pen the progression of the edema every hour. So we discourage now to use a marker pen to mark the child. We use the micropore, small micropore, and mark the level of the edema as it progresses. Okay. I think we've shared some video with Dr. Lim just now, which she will actually share with everyone else. So again, I said just now, picture paints 1,000 words. So we always ask, if you take picture of the bitten area, we take it as a serial. You can see the progression, as I said, cannot just at the area, but it can actually spread as well, the necrosis over time. So this is after several hours, and this is after 1 day later. You can see it's not just spreading, but also mottling. So what you see here on the skin is going to be different from what is under the skin. It's actually worse. The area of necrosis is worse. So when we actually do what you call tissue debridement, we see that underneath the skin is even more tissue is damaged. What appear on the skin, maybe 75% of what's the tissue damage underneath. Okay, so indication for first time, are you still going to call orthopedic for every snake bite case that has swelling? The answer is no. Okay, the first thing that you need to understand is fasciotomy is no longer the reason why someone is referred to orthopedic. Okay, the someone referred to orthopedic or surgeons is now only for wound debridement, if that is any indication. Fasciotomy is already out of practice because we have already antivenom to treat the patient from the signs of local tissue envenomation like this, swelling. Okay, so no more fasciotomy. What we encourage to do is also now to check the intercompartmental pressure. So we can do this either by direct tonometry, okay, or by ultrasound. We call the focus. We use focus, but the one that we do is called DRAF, DRAF. So we look for the arterial flow, retrograde arterial flow in that affected limb. So this all helps us in terms. There's a non-invasive, of course, help us establish whether is it a fasciotomy or not. Because as you can see, this is unnecessary fasciotomy. Somebody got bitten by a snake. This is our recent cases in KL here. Immediately fasciotomy, baru berapa jam dia sampai kat mesti dah buat pasal macam ni. Antivenom pun tak ada bagi lagi. So it's really debilitating for a patient. They might survive the snake bite, but they might have a scar for that with them iatrogenic scar with them for the rest of their life. Especially if you have a children, then it's not going to be beautiful for them. They're still growing. All right. So this is the ultrasound, as I said just now. We call pulse. You can watch this later. I don't have to go through the video. We can just proceed. So investigation. What should we send? As I said just now, these are the three things that we look for. Mostly full blood count, because it has component of the WBC and also the platelet count. Okay. Renal function test, yes, some you can do as a basic initial test to see. But coagulation profile is one of the things that we do regularly. And then the other coagulation issues, for example, perinorogen and D-dimer. We have a case now in Kulim, Kedah. Yeah, your hospital, right? Kulim case arrived 2 days ago, bitten by Rhabdophis species, and the patient developed coagulopathy. Go have a look at the patient. Patient is in the medical ward now, I think. Okay, so it developed full-blown coagulopathy within just less than 2 hours after bite. We don't have the antivenom for that patient. We don't for that species, but we manage with giving FFP, and cautiously giving FFP. Not all patients require this. If you have the antivenom, we give the antivenom first. But FFP is just we don't have anything else. So that's another indication. You have to look at the indications of giving blood products for envenom patient, for example, especially those can cause coagulopathy. Now, blood test, as I said, the patient already arrived to emergency. We straight away know the species name because the patient took a picture of the snake, and then we straight away asked the doctor to do a cross matching, and lo and behold, immediately patient came back with gum bleeding and so on, definitely a sign of coagulopathy. So the FFP was administered quite early when the patient is still in the emergency department. All right, and of course check the urine. In this patient, for example, causes hemolysis, and also coagulopathy. Patient had hematuria as well. All right. If it is a sea snake, then most of the patient will have rhabdomyolysis, and you will have myoglobinuria, black colored urine. All right, so another test beside that we can do is called 20-minute whole blood clotting test. This is actually just to determine whether the snake is a pig viper that causes hematotoxicity. So if you don't have a lab test, then this is a basic test that we can do. KK can do as well. Okay, just take 2 ml blood. Most importantly, need to put in a clean glass container, a small bottle, for example, but not washed, never been washed with soap as well, right? Because you need the surface to be rough so that you can start the coagulation, the contact coagulation profile, contact pathway can take place for clotting to start. And after 20 minutes, two things that can happen. Either it's clotted or unclotted. If it is clotted, then it's normal. There's no coagulopathy. If it's unclotted like this, most likely that if you do that on the patient that came 2 days ago from the Rhabdophis patient, the blood will be like this, clotted. And then lo and behold, in the coagulation profile that we send, is actually off the chart, cannot be read, right? INR cannot be read, PTA, PTT cannot be read. So it's more off the scale. So patient was bleeding from the gum as well at the time. So if it is like this, then we know that this is actually caused by a bite from a snake that can cause coagulopathy. So most of the time in Malaysia, the one that can cause coagulopathy is the pit vipers. But as we see 2 days ago, the case was not from a pit viper. It was from a different species or a different genus, Rhabdophis, the keelbacks, or from the group called Natricinae, okay, in Malaysia. So they can cause, they are not front fang, they are back fang, but they can cause a bite that deliver venom, and the venom can actually cause bleeding and also coagulation profile issue. So this is a small short video about what we do when we are bitten by a snake. I think they also provided you with this video, I think in your notes.
As you can see, this is a snake bite monitoring chart that we use. It should be performed hourly for the first 12 hours. We need to fill in the patient information and the sign and symptom present. The chart summarizes the commonly observed sign and symptom due to the snake envenomation. Monitor for the general condition of the patient. Take if the patient have drowsiness, vomiting, or abdominal pain. The sign and symptom may vary according to the different snake bite. In addition, we also need to look at the local effect that occur in the patient such as dermonecrosis, public discoloration of the skin or blister. Measure the size if present.
Next, we examine for the neurotoxic effect which often shown in electric bite like cobra, crate, and sea snake. This should be performed at least hourly for the first 12 hours. Firstly, ptosis. Ask the patient to look up and observe the upper eyelid. If ptosis present, upper eyelid outward movement will reduce or absent. Secondly, we observe for the external ophthalmoplegia by asking patient to follow the movement of object from patient's left to the patient's right. The affected eye unable to follow in certain direction because of the weakness of the extraocular eye muscle. Next, dilated pupil. This is a sign of envenomation of cobra, crate, coral, and sea snake. Then, broken neck sign as a result from paralysis of the neck muscle.
Dysphagia or swallowing difficulty and speaking difficulty is due to the muscle paralysis. Last neurotoxic effect that needs to be monitored is breathing abnormality with the poor respiratory effort due to the paralysis of the respiratory muscle. Using the serial assessment chart, we also need to document any hematotoxic effect and rhabdomyolysis sign. From the inspection of the wound, we document if there is a bleeding from the bite side. Also noted if patient complaining any other spontaneous bleeding from the nose, skin, gum bleeding, hemoptysis, hematemesis, or hematuria. Next, document rhabdomyolysis sign. Ask the patient of any generalized muscle pain and muscle tenderness on palpation. We need to monitor if any dark urine present.
Okay, so you can look at the video later. So let me just finish off with how do we scan, diagnose whether envenomation or not. It's actually either it is local, mostly start with local. There's no such thing as suddenly straight away systemic. So there's always sometimes some local effect and then followed by systemic envenomation. So some snake can have variable local effect as well, some very severe. With tissue necrosis, but some actually highly neurotoxic snake, for example, sea snake or coral snake, the local effect is not actually causing much problem. Some swelling, a little bit like swelling, but no tissue damage. Okay. Now, the question that we always been asked, difficult for us, is to give antivenom or treat conservatively, or manage or continue. But at any one time, our patient, especially children, we have to monitor them closely, more frequently, for the vital signs. For of course, some of them require cardiac monitoring for cardiotoxic effect, and also most of the time, as I said earlier, early stosis. So these are the signs that we always look for in what we call the syndromic approach of the patient, as the video suggests just now. So this will give us the indication to give or not to give antivenom. So the detail about it is in the KKM guideline. Please have a look on the snake bite. So again, if you're not sure, you can always call Rex. Okay. So we will actually advise you what antivenom to give. Betul ke ada antivenom, or should you monitor for the next one, take another blood test. Most of the time you will be looking at what we call the trend of all the parameters that we monitored just now, okay, including blood tests as well. The trend, one blood test does not is not a trend. Okay, it's a trend. Is at least you have to have three different readings for you to give an idea of where it is going. The trend, is it going up, is it going down, is it the same? Okay, so those are the things that we have to monitor. So to give or not to give antivenom, it depends on the sign symptoms. So for Malaysia, we have already selected antivenom. We do not manufacture antivenom in Malaysia. We have to import. So these are the antivenoms that we have for the land snake of Malaysia. We have one antivenom for the sea snake as well, okay, which we have to import from Australia. All the land snake antivenom for Malaysia is imported from Thailand. As you can see, it has many forms. Some are very specific to one single species of the snake, and the others are combination into one vial, where we have 3 or 4 different species into one vial, or okay, one antivenom called the polyspecific antivenom. Okay, this is as you can see here, this is a polyspecific for hematotoxic, and this is a polyspecific for neurotoxic. Doesn't mean it can be used for all snake bite. Okay, for example, that patient just not 2 days ago came with rhabdophis bites causing coagulopathy, hematotoxic, right? We cannot use this because it is not in the list of the species this antivenom is raised from. Okay, so that's why we do not use hematopolyvalent for that patient that was bitten by rhabdophis in Kulim. Okay. So to give antivenom, we need to prepare first and make sure that you have the right antivenom. And one vial is not one dose. Sorry, one dose is not one vial. So in Malaysia, as I said, we have depending on the symptoms and signs, neurotoxic or not, or the species, it can be either 3 vials, or it can be either 5 vials, or it can be 10 vials as a first dose, right? One vial first dose is only for seasoning, right? So we need to prepare this antivenom beforehand. So most of the emergency department will have a DDA box. They have it already in the emergency department. Otherwise, you need to call your pharmacy. So first thing you need to do is to reconstitute the antivenom. It comes in the powder form, except for sea snake, it's in the liquid form. But for the land snake, the antivenom is in lyophilized powder form. You need to reconstitute first. It comes with a 10 mils water for injection, and you mix it first. Okay, do not shake too hard. Okay, this is a protein, something that you do with streptokinase as well. You roll or you swirl, okay, to dilute it. Once everything is diluted, then you withdraw, and then you need, once everything is reconstituted, you need to withdraw for dilution. So you add on into the other liquid to further dilute. So for children, you just have to know your body weight, how much you want to calculate. It's either 5 mils per kilo or 10 mils per kilo, depending. So you can actually add on to the antivenom. The antivenom is always in 10 mils. Okay, once you reconsider, it's always 10 mils. So how much added to the volume is based on your child's body weight lah, for the dilution. Then you start the infusion. Infusion rate is, there's no more test dose. So we say, oh, we need to do test dose, inject under the skin, see if reaction after 30 minutes. That's wasting time. So what we do is just straight away you plug in for infusion. Just start very slow first, slow rate, either 2 mils per minute, or actually 3 mils per minute. So if after 10 minutes there's no reaction, okay, then you can increase the rate to 5 mils per minute to complete the antivenom infusion within less than 1 hour. Okay, so at all times during this process of giving antivenom, you need to closely monitor the child. Do not leave the child alone. Okay, I'm sure you are familiar with this. Sometimes a busy emergency department, patient can get left alone on their own without proper supervision, proper observation. Next other question is to give antivenom again or not. So once the first dose is done, the first 3 vials is done, for example, or first 10 vials is done, when do you want to repeat again? This all depends on how the patient reacts or respond to the antivenom that you give. Okay, the antivenom, if it's correct, if it's in the right amount, then the patient will have a positive response in terms of all the other symptoms of envenoming will start to minimize or to go away. Tadi tosis dah ada, sekarang dah tak ada tosis after giving antivenom. Okay, so continuous observation of the patient is important. Will tell you whether the patient is responding or not to your therapy. For example, if let's say a patient did not respond, actually become worse after you give antivenom, that's a sign what we call the failure of therapy. The question is whether did you give the right antivenom or not? That's first thing that it comes to your mind. If somebody you give but it becomes worse, is it the right antivenom or not? Second, is it adequate amount or not? Okay, if it's adequate amount, it should not be any issue. So if it is inadequate amount, then there's a possibility you may need to top up the antivenom. So the next antivenom dose is almost the same as the first antivenom dose. Okay, so the only difference is the duration. When do you want to give the top up dose? So most of the time we say you observe 1 or 2 hours after the first initial dose, then you decide whether to give a next dose or not. It's typically true for the neurotoxic snake. The neurotoxic snake is very special because you can see the response very fast after giving antivenom. But for the hematotoxic snake, you have to wait for at least 4 to 6 hours to see whether there is an improvement in the blood test that you do, coagulopathy, PTT, and also your platelet count. So that takes time, a bit longer. So you observe after you give the antivenom, you observe for 6 hours after the antivenom is completed, then you repeat the blood test. Okay, that's for those with coagulopathy, coagulation issue. Okay, this is what happened to that patient in Kulim also. Even though we not repeat more frequently, we say at least every 12 hours. Okay, that we see if he needs to be given the FFP again or not. So that's the importance of reassessment and monitoring to see the response. And this is the response that we normally get in a child, for example, with ptosis, just now tak boleh buka mata, now we do the test again, the child can actually move for that right after giving the first dose of the appropriate antivenom for this child. This is the case that we manage in Indonesia. Okay, so any reaction, antivenom can cause reaction. It can cause early reaction or late reaction. The early reaction is, as you know, is anaphylactic. You can have a rash and you have some difficulty breathing, angioedema, or you can have a temperature spike after antivenom because it's protein, it's a pyrogenic reaction. Late serum sickness is usually typical, is after 5 days after giving, it's later, it's not now. So they're all treated almost the same, but serum sickness we give steroids as well. So these are the treatment for reaction: adrenaline, fluids, antihistamine, steroids, and antipyretic. Okay. So summary, basically call Rex if you have any issues. You're not sure of anything, please call Rex. In each hospital, there is a Rex group for that hospital. Get yourself into that group. Just ask the administrator, which typically the emergency physician specialist in that hospital will add you to the group. Okay, or you can just call us, call me directly, and then I will add you to the group that you are affiliated to. All right, so that's it. Thank you very much. Let's open for a few minutes question and answer. Do we have time? Do we have time?
Yes, we have 2 minutes. Dr. Pandun, any question from the floor?
Sorry, I was a bit rushing because I thought that we're supposed to finish at 10.
Yeah,
I had to make up speed talking.
Assalamualaikum, Prof. Khaldun. I just
Waalaikumsalam.
wondering, in the case of confirmed snake bite, for example, the patients really identified it was a Malayan pit viper, and clearly is a systemic envenomation. The platelet is already 77 on the first sitting of our review, and apparently once we started the anti-venom, the anaphylactic response goes into shock, for example. So should we continue the antivenoms with the support of the adrenaline, or should we treat clinically using the FFP like the case that you handled before this?
Okay, so first, a very good question. Thank you very much for that. First is actually you already established that the child require antivenom, right? This is coagulopathy from pit viper bite. So obviously you have to give the antivenom. So which antivenom you give? In Malaysia, we have two different antivenom for pit vipers. One is for the Malayan pit viper, and the other one for the green pit vipers. Okay, the green pit vipers ni ada called Tremoristris complex group. There are several species in that. So that's one thing. So you have a choice of which one antivenom you want to give first. Let's say you give the right antivenom. This is yes, you said it's from Malayan pit viper. You give Callosalasma rhodostoma and AV. First dose is actually 3 vials. Adult or child, the dose is the same. Because the amount of venom, the snake doesn't say, oh, child lah bagi sikit. Ada, adult kita bagi banyak. Tak. It's a bite is a bite, and the amount of venom that enter the body will depend on the to neutralize it will require the same amount of antivenom, child or adult. Okay, the only difference is the volume that you give just now, as I said. So you bagi start, and then katalah after 10, I don't know how long you give and start to have the cardiogenic shock. Anaphylactic shock. So obviously you have to stop giving the antivenom, not throw away the antivenom, please. Okay, just stop administration, treat the anaphylaxis. Okay, is it anaphylaxis? Yeah, treat the anaphylactic shock, and then as your schema lah. Kalau you buka dalam pediatric protocol tu ada schema for anaphylactic shock. So treat the child first. After the child has responded, hopefully responded, whether intubate or not intubated, back the time yang left over. Tadi katalah you dah low, okay, then you dah increase to higher rate, and the higher rate dia jadi reaction. So when you want to restart back at a lower rate, or if you may want to continue pun, you will continue at the lower rate. So the completion of the antivenom can be more than 1 hour. Then I cakap tadi, once you start to give, your target is to give finish within 1 hour, means less than 1 hour. But in the situation, you may want out of caution, the time to finish the antivenom may be longer. All right. So give antivenom, because that's the only antidote for the envenomation. FFP will not correct. That's the danger as well. Giving a blood product is the as long as there is venom still in the circulation of this child that causes the coagulopathy, consuming all the factors, okay, and some in the callosal asthma is typical to cause thrombocytopenia as well. So you will actually when you give the FFP, it will still be consumed by the venom still in circulation. You understand? So it will not really fully correct. It will still be consumed, and you can have a risk of microthrombi, okay, forming. So when you have a real microthrombi, you have to look at your kidney function as well. So that's why FFP in terms of procoagulant snake bite can actually cause more problems, more danger. All right. So that's why when we give for example, the 2 days ago yang Kulim case tu, coagulopathy, right? So we give FFP because we don't have the appropriate antivenom for that. And the patient is bleeding. So when we give the FSP, the bleeding starts to slow down and so on. But we still continue monitoring, and one of it is to monitor the kidney function. Patient had acute kidney failure before coming to hospital. So we are not sure, but we still continue. The creatinine increased a bit, but it has tapered off after we repeat the blood test again after 6 and 12, 6 hours after the administration. So it's not worsening kidney function. So these are the things that you have to bear in mind, right? Don't throw away the antivenom. Antivenom is not cheap, right? So it's the only antidote for envenomation. One, if you have a reaction, treat the reaction first. Withhold, treat reaction, and once it is already resolved, come back, restart the antivenom, and you repeat whatever blood. If I say, for example, coagulopathy, your case, coagulopathy is going to be thrombocytopenia and also PTAPT 6 hours after completion of that of that finishing of the antivenom. Okay.
I hope now our viewers have a clear picture on how to manage and monitor patients who are bitten by snake, and also hope we will be able to recognize a few types of snake as shown by Prof. Khalid just now.
Oh.
So thank you, Prof. Khalid, for your talk again.